Trisomy 21 represents the most common chromosomal abnormality compatible with life, affecting approximately 1 in every 700 to 800 live births. This makes Down syndrome a diagnosis you'll encounter regularly throughout your NICU career, requiring both medical expertise and compassionate family support. Unlike other autosomal trisomies that end in early miscarriage, Trisomy 21 uniquely permits survival because chromosome 21 is one of the smallest autosomes with fewer genes, creating a genetic imbalance that's compatible with development. 3 distinct mechanisms produce Down syndrome, each with different implications for genetic counseling. Non-disjunction accounts for 90% of cases, representing failure of chromosome 21 pairs to separate properly during maternal meiosis. These cases occur sporadically with normal parental karyotypes, so we counsel families that this represents a random event, not something they caused or could prevent. Translocation Down syndrome comprises 3 to 5% of cases, but carries outsized importance because one parent might carry a balanced translocation, dramatically increasing recurrence risks for future pregnancies. Here, chromosome 21 material attaches to another chromosome, often chromosome 14. Mosaicism, the rarest form at 1%, results from mitotic errors after fertilization. Some cell lines contain the extra chromosome while others remain normal. These infants often show milder phenotypes, though predicting severity proves challenging. The maternal age effect creates the epidemiological pattern we observe in practice. Risk increases dramatically with advancing maternal age because oocytes begin division during fetal development, but don't complete it until ovulation decades later. This prolonged meiotic arrest allows accumulation of factors that compromise proper chromosome separation, shaping both prenatal counseling practices and genetic risk assessment. The relationship between maternal age and Down syndrome risk represents one of the most well-established patterns in clinical genetics, shaping how we approach prenatal counseling and helping families understand their individual risk factors. The risk increase follows an exponential rather than linear pattern, accelerating dramatically after age 35. This reflects the biology of female meiosis, where oocytes arrested since fetal development accumulate molecular damage over decades. The proteins holding chromosome pairs together, called cohesins, deteriorate with time, like rubber bands losing elasticity after years of tension. By the time an oocyte completes meiosis decades later, these weakened connections increase the likelihood of improper chromosome separation. Advanced maternal age, traditionally defined as 35 years and older, marks where this risk acceleration becomes clinically significant. However, risk exists along a continuum rather than a magical boundary. A 34-year-old faces slightly lower risk than a 35-year-old, not dramatically different risk. Understanding this continuous curve helps families make informed decisions. This exponential increase carries profound counseling implications. While younger mothers can have babies with Down syndrome, the probability increases so substantially with age that different approaches become appropriate. A woman in her 20s might receive reassurance about low baseline risk, while someone in her 40s requires detailed discussion about elevated probabilities and testing options. An often overlooked fact, approximately 1/4 of Down syndrome cases result from paternal rather than maternal meiosis errors. This reminds us that chromosomal abnormalities don't exclusively relate to maternal factors and helps explain why young mothers occasionally have affected babies. This age-risk relationship extends beyond individual counseling to influence public health policy, from population screening protocols to insurance coverage for genetic testing, helping you provide context when families ask why certain tests are recommended based on age alone. Recognizing Down syndrome at delivery requires understanding which physical features appear consistently in newborns versus those that develop over time. While textbooks list dozens of characteristics, certain features prove most reliable for immediate identification. Hypotonia stands as the single most important finding, affecting nearly every infant with Trisomy 21. This profound muscle tone reduction creates that characteristic floppy baby presentation where the elbow easily crosses midline during the scarf sign, and the infant slips through your hands during vertical suspension. This hypotonia impacts everything from respiratory effort to feeding ability, making it both a diagnostic clue and immediate management concern. The facial constellation creates a recognizable pattern. Upslanted palpebral fissures combine with epicanthal folds and a flat nasal bridge to create the characteristic appearance. Small low-set ears often fold over to upper helix, while brachycephaly becomes more pronounced as infants spend time supine due to their hypotonia. Hand examination reveals single palmar creases in about 45% of infants with Down syndrome, though remember that 4% of the general population also has this finding. Fifth finger clinodactyly occurs from hypoplasia of the middle phalanx, and combined with short, broad hands, these findings strengthen clinical suspicion. The sandal gap, that increased space between the first and second toes, proves remarkably consistent and often catches parents' attention. Brush field spots appear as white or light-colored spots arranged around the iris periphery, becoming more visible in lighter eyes. Understanding why these features cluster together helps explain the pathophysiology. Extra chromosome 21 material affects early embryological development, particularly neural crest cell migration and collagen production, creating the characteristic facial features, while altered muscle development produces the universal hypotonia. Recognizing these patterns allows confident clinical diagnosis while awaiting chromosomal confirmation. Beyond characteristic physical features, Down syndrome creates a constellation of internal anomalies that fundamentally shape our NICU management approach. Understanding these associations transforms how we evaluate and monitor these infants from admission. Cardiac defects affect half of all infants with Down syndrome, making echocardiography mandatory. The specific defect pattern differs from the general population. Atrioventricular canal defects, where the heart's center fails to form properly, occur far more frequently because trisomy 21 specifically disrupts endocardial cushion development. This complete mixing lesion creates both atrial and ventricular shunts with abnormal AV valves. While VSDs, ASDs, tetralogy of Fallot, and PDAs also increase in frequency, their distribution differs from typical congenital heart disease patterns. The combination of hypotonia affecting respiratory mechanics and significant cardiac disease creates complex management challenges. These infants often struggle with feeding due to both low tone and congestive heart failure, requiring careful balance between nutrition and fluid management. Gastrointestinal anomalies present both immediately and later. Duodenal atresia occurs 12 times more frequently than in the general population. That classic double bubble sign should immediately trigger consideration of Down syndrome. Hirschsprung disease presents later, with chronic constipation or acute enterocolitis due to disrupted neural crest migration. The dramatically increased leukemia risk represents one of the most striking long-term associations. Children with Down syndrome face 10 to 18-fold increased risk, including both acute lymphoblastic leukemia and transient abnormal myelopoiesis that occurs exclusively in Down syndrome. Extra chromosome 21 carries genes involved in hematopoiesis, and their overexpression disrupts normal blood cell development. Thyroid dysfunction and hearing loss require long-term surveillance. Hearing loss affects over 75% through structural ear abnormalities, chronic otitis media, and sensory neural components. These associations reflect how trisomy 21 disrupts fundamental developmental pathways throughout the body, explaining why comprehensive evaluation and ongoing monitoring are essential. Trisomy 18 or Edwards syndrome presents a dramatically different clinical picture than Down syndrome, despite sharing the same underlying mechanism of autosomal trisomy. The incidence of 1 in 6,000 to 8,000 live births makes it the second most common autosomal trisomy in live births, yet considerably rarer than Down syndrome. The statistic that only 5% of conceptuses with trisomy 18 survive to birth reveals the severe genetic imbalance created by an extra chromosome 18. Chromosome 18 contains significantly more genetic material than chromosome 21, and triplication of these genes disrupts fundamental developmental processes. Most affected pregnancies end in spontaneous miscarriage. When families reach your NICU with a live-born infant with trisomy 18, they've already beaten overwhelming odds. The prognosis remains sobering even for those who survive to delivery. 90% of infants die within their first 6 months, with only 5% reaching the first birthday. These statistics reflect multiple severe malformations affecting cardiac, neurological, and other vital systems. This universally poor prognosis distinguishes trisomy 18 from Down syndrome and fundamentally alters our approach to family counseling and medical decision-making. The 3-to-1 female predominance in live births reflects even higher intrauterine mortality rates for male fetuses, suggesting that the genetic imbalance combined with having only one X chromosome proves particularly lethal. These facts translate directly into clinical practice. Understanding the poor survival statistics guides honest but compassionate discussions with families about resuscitation preferences, invasive interventions, and comfort care options. Some families choose full intervention, hoping their child will be among the 5% who survive the first year, while others opt for comfort-focused care. Unlike Down syndrome, where public awareness and support groups abound, families facing trisomy 18 often feel isolated, requiring comprehensive support during this difficult experience. Edwards syndrome creates a constellation of physical features so distinctive that experienced practitioners can often recognize affected infants immediately after delivery. These features result from profound developmental disruption caused by 3 copies of chromosome 18 affecting multiple organ systems in predictable patterns. The pathognomonic triad occurs with such consistency that their presence virtually confirms the diagnosis. Clenched hands with overlapping fingers represent the most recognizable finding, where the index finger overlaps the third and the fifth overlaps the fourth, creating a distinctive fist that resists passive opening. This isn't simple flexion from increased tone, but rather a fixed deformity from abnormal tendon and muscle development. Rocker bottom feet, where the heel protrudes posteriorly while the arch convexes outward, create a curved sole resembling a rocking chair's base. This results from vertical talus and abnormal tarsal bone development. Parents often notice these during prenatal ultrasounds, describing them as backwards feet. The prominent occiput creates a strawberry-shaped skull distinctly different from Down syndrome's brachycephaly. This elongated shape results from premature suture fusion combined with brain underdevelopment. Severe intrauterine growth restriction affects virtually all infants, typically presenting with birth weights below the 3rd percentile, despite full-term gestation. This reflects cellular dysfunction from genetic imbalance rather than maternal insufficiency. Micrognathia compounds feeding difficulties and often necessitates special positioning for airway management. Combined with low-set, malformed ears, this creates a characteristic facial profile. The 90% incidence of heart defects makes cardiac evaluation mandatory. Unlike Down syndrome's endocardial cushion defects, Edwards syndrome causes varied cardiac malformations, including VSDs, ASDs, and complex defects. That teaching pearl, clenched hands equals think Edwards, provides rapid diagnostic guidance while awaiting karyotype confirmation. The clinical course of Edwards syndrome follows predictable patterns that help us prepare families for the challenging journey ahead while providing compassionate, appropriate care. Understanding these patterns enables us to anticipate complications, guide medical decision-making, and support families through extraordinarily difficult choices. Severe intrauterine growth restriction typically brings these infants to our attention before delivery. Birth weights often fall below the 3rd percentile despite full-term gestation, reflecting profound cellular dysfunction from trisomy 18. This symmetric growth restriction affects head circumference, length, and weight proportionally, continuing postnatally and compounded by universal feeding difficulties. Feeding difficulties arise from multiple converging factors. Micrognathia creates mechanical challenges for latching and sucking. Hypotonia affects coordinated suck-swallow-breathe patterns. Many infants have cleft or high-arched palates that further complicate oral feeding. Even tube feeding faces challenges from poor gut motility and gastroesophageal reflux, creating a cycle of inadequate nutrition that proves difficult to break. Apneic episodes represent one of the most distressing aspects for families and staff. These aren't simple breathing pauses responding to stimulation, but central apneic events reflecting brainstem dysfunction. Infants lack normal respiratory drive, leading to prolonged apnea that doesn't respond predictably to conventional interventions. Central apnea emerges as the leading cause of death, often occurring suddenly, despite previous stability. Congestive heart failure from nearly universal cardiac defects provides another common pathway. The combination of significant structural heart disease with poor respiratory drive creates often insurmountable management challenges. Given this trajectory, comfort-focused care often becomes the most appropriate approach, focusing on quality of life, symptom management, and family bonding. Recent advances have extended survival for some infants, but these interventions rarely change the ultimate prognosis. Families choosing aggressive intervention deserve the same support as those choosing comfort care, with honest discussions about extended survival, including profound developmental disabilities and continued medical fragility. Trisomy 13, known as Patau syndrome, represents one of the most severe chromosomal abnormalities compatible with live birth. The incidence of 1 in 12,500 to 21,000 live births makes it the fourth most common autosomal trisomy, considerably rarer than both Down syndrome and Edwards syndrome. This rarity reflects profound developmental disruption caused by an extra chromosome 13, which contains extensive genetic material crucial for early embryogenesis. Only 2 to 3% of conceptuses with trisomy 13 survive to birth, revealing extreme lethality compared to Edwards syndrome's 5% survival rate. The vast majority of affected pregnancies end in early spontaneous miscarriage. When chromosome 13 is triplicated, the disruption to fundamental developmental processes proves so severe that basic organ formation cannot proceed normally. Families reaching your NICU with a live-born infant with Patau syndrome have experienced an extraordinarily rare event. These parents may have undergone extensive prenatal counseling about intrauterine demise likelihood, making live birth both unexpected and emotionally complex. The prognosis remains exceptionally grave. With 80% mortality during the neonatal period, most infants will die before leaving the NICU. Fewer than 5% survive to 6 months, reflecting how this condition affects fundamental life-sustaining processes rather than individual organs. The key distinguishing feature, midline malformations, provides crucial diagnostic insight. Trisomy 13 specifically disrupts midline development during embryogenesis. Normal development requires cells to migrate and fuse at the body's midline to form unified structures. The genetic imbalance profoundly disrupts this fusion process through disruption of the sonic hedgehog signaling pathway, crucial for midline structure formation. This creates a pattern so consistent that recognizing any significant midline defect should immediately trigger consideration of Patau syndrome. Understanding this rarity and severity helps calibrate our response, demanding careful consideration of care goals from the outset, unlike other trisomies. The classic features of Patau syndrome create a recognizable pattern centered around failed midline development, reflecting how trisomy 13 disrupts fundamental embryological processes. These features prove so consistent that recognizing the pattern enables rapid clinical diagnosis while awaiting genetic confirmation. Holoprosencephaly, affecting over half of infants with Patau syndrome, represents the most severe manifestation of midline failure. During normal development, the prosencephalon must divide into 2 cerebral hemispheres. In holoprosencephaly, this division fails partially or completely, ranging from allobar forms, where the brain remains undivided, to semilobar and lobar forms with incomplete separation. This catastrophic malformation explains secondary features. Closely spaced or cyclopic eyes result from failure of optic vesicles to separate, while mid-face hypoplasia occurs because brain development drives facial bone growth. Cleft lip and palate represent another midline fusion failure, occurring when maxillary and medial nasal processes fail to unite during weeks 6 through 7 of gestation. In Patau syndrome, these clefts often appear more severe than isolated cases, with bilateral complete clefts extending through both hard and soft palate frequently occurring. Scalp defects, specifically aplasia cutis congenita, creates striking findings where skin never formed, leaving exposed tissue or thin membrane covering the skull. These defects typically occur at the vertex along the midline, reinforcing the pattern of midline developmental failure. Postaxial polydactyly involves extra digits on the ulnar side of hands or fibular side of feet. The additional chromosome 13 disrupts normal genetic pathways controlling limb bud development and digit formation. Severe eye abnormalities complete the clinical picture. Microphthalmia results in strikingly small, underdeveloped eyes, while coloboma creates keyhole-shaped defects when the optic fissure fails to close properly. The teaching pearl. Holoprosencephaly plus polydactyly equals Patau syndrome until proven otherwise. This combination proves so specific that encountering both features warrants immediate genetic evaluation. Holoprosencephaly is a severe brain malformation where the forebrain fails to divide into cerebral hemispheres during early development. While you may never see a case due to high mortality rates, understanding this condition helps you recognize the clinical pattern when it does present and supports families facing these devastating diagnoses. The condition exists on a severity spectrum. Allobar is the most severe form with complete failure of brain division and dramatic facial abnormalities like cyclopia. Semilobar shows partial division, while lobar holoprosencephaly may have relatively normal facial features and better survival potential. What matters for your practice is recognizing the clinical presentation. Midline facial defects like cleft lip and palate often signal underlying brain abnormalities. These infants struggle with temperature regulation because their hypothalamus doesn't function properly. They may develop diabetes insipidus from posterior pituitary problems, and seizures are common. The connection to trisomy 13 is significant. When you're caring for a trisomy 13 infant, holoprosencephaly may be part of their complex medical picture. Your nursing focus becomes managing temperature instability, monitoring fluid balance carefully, and recognizing seizure activity early. Perhaps most importantly, these families need honest, compassionate communication about prognosis. Your role involves supporting them through incredibly difficult decisions, while providing skilled care for medically complex infants who may have limited survival potential. Turner syndrome highlights a unique paradox in genetics. While loss of any autosome is lethal, loss of one sex chromosome, specifically the X, can allow survival. This makes 45X the only viable human monosomy. Despite its NICU relevance, Turner syndrome is rare due to high prenatal loss. Over 99% of affected conceptuses miscarry, meaning only 1 in 1,000 survives to birth, making each case an exceptional outcome. Turner syndrome affects only females because the X chromosome carries over 1,000 essential genes. Complete absence of an X, as in 45Y, is incompatible with life. But if males live with one X, why can't females? The answer lies in X inactivation. In typical females, one X is inactivated in each cell, but 15 to 20% of X-linked genes escape this process. These genes often have counterparts on the Y chromosome, giving males a functional backup. Females with Turner syndrome have only one copy, leading to haploinsufficiency. The SHOX gene is a key example, explaining their short stature. Turner syndrome karyotypes vary. Only about 50% are classic 45X. Others show mosaicism or structural abnormalities, like deletions or isochromosomes, accounting for wide differences in clinical presentation. An important detail: in about 80% of cases, the single X is maternal, suggesting the paternal sex chromosome was lost, likely due to instability during male meiosis. This results in a fixed X activation pattern, unlike the random X inactivation in typical females, which may influence phenotype. Turner syndrome often reveals itself at birth through a distinctive set of physical findings, even before genetic results are available. These features arise from haploinsufficiency of genes that escape X inactivation, affecting both structure and development, and guiding our immediate management. The webbed neck, perhaps most recognizable sign, stems from lymphatic abnormalities in utero. Fluid buildup creates cystic hygromas, which resolve partially before birth, but leave behind excess skin from ears to shoulders. Parents often notice this right away, describing the neck as too wide, or asking about extra skin. Shield chest refers to a broad chest with widely spaced nipples, reflecting abnormal thoracic development. This, combined with the webbed neck, forms a striking upper body shape. It's not just cosmetic. These changes can influence cardiac and respiratory function. Lymphedema of the hands and feet continues the same lymphatic issues. At birth, infants often show non-pitting swelling on the dorsal surfaces due to underdeveloped lymph vessels. While it typically improves over time, some may have chronic or recurrent swelling. Nail hypoplasia, small curved nails, often accompanies this edema. Cardiac anomalies are the most serious concern. Bicuspid aortic valve affects 30% of cases and increases risk for stenosis or regurgitation. Coarctation of the aorta, seen in 10%, may require urgent repair. Both reflect disruptions in neural crest cell development, also tied to X-escape gene function. Short stature is usually present at birth, often with length below the 10th percentile. This stems from Schoch's gene haploinsufficiency. Unlike other causes of short stature, Turner syndrome involves slowed growth over time, making early recognition important for growth hormone therapy planning. Each of these features tells a story of disrupted development tied to specific genetic mechanisms. Understanding these connections helps us anticipate complications, guide testing, and support families, not just in the newborn period, but across the lifespan. Managing Turner syndrome starts in the NICU and continues across childhood. A clear understanding of each necessary screening helps prioritize immediate actions and prepare families for long-term care. Cardiac evaluation is the top priority. Every infant with Turner syndrome requires an echocardiogram, no exceptions, regardless of symptoms. Up to 40% have significant heart defects, including bicuspid aortic valve and coarctation of the aorta. Coarctation can be missed early if the ductus is still open, but may cause sudden collapse when it closes. The echo should specifically assess aortic valve structure and arch anatomy. Coarctation requires urgent surgical consultation. Bicuspid valve, even if asymptomatic, warrants lifelong cardiology follow-up. Growth management offers early intervention with major impact. Without treatment, adult height may range from 4'5" to 4'11" due to Schoch's gene haploinsufficiency and absent pubertal growth. Growth hormone, usually started between ages 4 to 6, can add 5 to 10 centimeters. Early referral maximizes benefits, so discharge planning should include a discussion about therapy, not for cosmetic reasons, but to reduce the physical and social burden of short stature. Hearing assessment is essential due to a high risk of both conductive and sensory neural hearing loss. Structural ear differences and cochlear dysfunction can lead to speech delays. Newborn hearing screening must be taken seriously. Any abnormal result should prompt ENT referral, not just retesting. Renal ultrasound detects anomalies in 30 to 40% of cases, including horseshoe kidneys, solitary kidneys, and collecting system duplications. While often asymptomatic, these can increase infection risk or influence medication dosing. Early detection allows for proactive management, including prophylaxis and follow-up. Together, these evaluations provide a roadmap. Each targets a specific risk. Echo prevents cardiac emergencies, growth hormone improves height outcomes, hearing screening supports development, and renal imaging reduces long-term complications. Early, structured assessment empowers families and sets the stage for coordinated, effective, lifelong care. Beckwith-Wiedemann syndrome differs from chromosomal disorders we've discussed. It involves abnormal gene regulation on chromosome 11p15 rather than missing or extra chromosomes. Early recognition is essential given its distinct overgrowth pattern and management challenges. Though uncommon, 1 in 14,000 births, Beckwith-Wiedemann isn't rare in clinical practice. 85% of cases are sporadic with no family history, while 15% involve imprinting inheritance. Importantly, families should understand this wasn't caused by anything they did. Beckwith-Wiedemann is an overgrowth syndrome caused by disrupted gene imprinting on chromosome 11p15. The key gene is IGF-2, insulin-like growth factor 2. Normally, only the paternal copy is active, while the maternal copy is silenced, maintaining balanced fetal growth. In Beckwith-Wiedemann, this balance fails. Maternal silencing is lost, paternal regions duplicate, or other changes occur, creating excess IGF-2. This doubles the growth signal, causing cells to grow larger and divide rapidly. Clinically, Beckwith-Wiedemann presents with a recognizable triad. First is macrosomia, birth weight above the 90th percentile, often 4,500 to 5,000 grams, plus selective organ enlargement of kidneys, liver, and pancreas. Pancreatic overgrowth often causes hyperinsulinism and newborn hypoglycemia. Second is macroglossia, true tongue overgrowth from excess IGF-2. The tongue protrudes beyond the lips, potentially causing airway obstruction and feeding difficulties, requiring surgical reduction in severe cases. Third is abdominal wall defects, typically omphalocele, where rapid organ growth opaces abdominal wall closure, leaving contents herniated at the umbilical ring. Beckwith-Wiedemann is unique because chromosomes are structurally normal. The issue is gene expression, not genetic material. This creates overgrowth rather than undergrowth. Understanding this mechanism guides both immediate management of hypoglycemia, airway issues, and abdominal defects, and long-term care. The same growth signals increase childhood tumor risk, requiring regular surveillance. Beckwith-Wiedemann syndrome results from disrupted imprinting and IGF-2 overexpression. Early recognition, family counseling, and structured management optimize outcomes. Management of Beckwith-Wiedemann syndrome begins with addressing immediate neonatal concerns and planning for long-term surveillance. One of the most urgent issues in the newborn period is hypoglycemia, which occurs in up to 50% of affected infants. This low blood sugar results from hyperinsulinism, excess insulin production driven by beta cell hyperplasia in the pancreas. If not recognized and treated quickly, it can lead to seizures and potentially permanent neurologic injury. Prompt monitoring and glucose management are essential in the first days of life. Beyond the newborn period, long-term care focuses on cancer surveillance, particularly for Wilms tumor, a type of kidney cancer. The risk is significantly elevated in children with Beckwith-Wiedemann syndrome, so regular abdominal ultrasounds are recommended every 3 months until school age. This routine imaging allows for early detection and intervention if tumors develop. By combining close neonatal monitoring with structured long-term screening, we can reduce both immediate complications and future risks in infants with Beckwith-Wiedemann syndrome. DiGeorge syndrome is the most common microdeletion syndrome, involving deletion of about 3 million base pairs on chromosome 22q11.2. Despite affecting only 60 genes, this small deletion disrupts multiple organ systems during development, with an incidence of 1 in 1,000 fetuses. More common than any trisomy except Down syndrome, DiGeorge often goes unrecognized early, as many infants appear normal at birth with symptoms emerging gradually. The syndrome stems from one central problem: disrupted neural crest cell development. Neural crest cells migrate from the neural tube during embryogenesis to form structures throughout the body. The deletion, particularly of the TBX1 gene, impairs this migration. This single developmental pathway, neural crest dysfunction, explains DiGeorge's seemingly unrelated features. Heart defects occur because neural crest cells help divide the primitive outflow tract into separate vessels. Facial differences arise from neural crest contributions to facial bones. Thymic hypoplasia results from abnormal third pharyngeal pouch development, compromising T-cell production and cell-mediated immunity. Cleft palate reflex failed neural crest-mediated fusion. Hypocalcemia stems from underdeveloped parathyroid glands sharing the same embryologic origin. Understanding this unified mechanism, rather than memorizing isolated features, provides the framework for recognizing and managing this contiguous gene deletion syndrome. DiGeorge syndrome's clinical presentation spans multiple organ systems, with challenges beginning in the newborn period and evolving throughout life. Understanding how these features interconnect guides evaluation and prevents complications. Cardiac abnormalities are typically conotruncal defects. Tetralogy of Fallot is most common, potentially causing cyanosis during crying or feeding. Truncus arteriosus is more severe, with complete blood mixing causing cyanosis from birth. Interrupted aortic arch is the most critical emergency. Blood reaches the lower body only through a patent ductus arteriosus, leading to shock and acidosis when the ductus closes. Immune dysfunction varies widely. Complete thymic aplasia results in severe T-cell deficiency, while partial hypoplasia produces variable immunodeficiency. These infants may appear well, but struggle with viral infections or fail to respond to live vaccines. Hypocalcemia affects over half of affected neonates due to underdeveloped parathyroid glands. Unlike transient newborn hypocalcemia, this form is often profound and symptomatic. Seizures may be the first sign, but earlier clues include jitteriness and prolonged QT interval. Symptoms may appear within hours or take several days as maternal calcium support wanes. DiGeorge's complexity lies in how these issues compound one another, Cardiac defects complicate surgical recovery when T-cell deficiency is present, while hypocalcemic seizures add neurologic risk to already fragile infants. Diagnosing DiGeorge syndrome requires knowing when to test and coordinating multidisciplinary care from the start. FISH testing is the diagnostic gold standard, detecting the 22q11.2 deletion in 95% of cases using fluorescent probes. Results return within 24 to 48 hours, essential for acutely ill newborns. Testing all infants with conotruncal heart defects is now standard. 10 to 15% have the deletion, rising to 50% for interrupted aortic arch. The clinical pearl: conotruncal heart defect plus hypocalcemia should immediately raise DiGeorge suspicion. This combination is specific enough to prompt genetic testing even when other features are absent. Systematic management begins immediately. Calcium monitoring every 8 to 12 hours is essential, as hypocalcemia affects 60% of affected newborns. Treatment requires not just supplementation, but calcitriol, since many lack parathyroid hormone for calcium absorption. Cardiac imaging with echocardiography is mandatory for all suspected cases, even without obvious murmurs. If interrupted aortic arch is found, prostaglandin infusion must begin immediately, before shock develops. Immunology consultation guides tailored care through lymphocyte counts and T-cell subsets. This determines isolation needs, blood product requirements, irradiated products prevent graft versus host disease, and vaccine safety. Early identification shifts care from crisis response to proactive management, improving both immediate safety and long-term outcomes through coordinated multidisciplinary care.